All right, good morning. We're going to get started. I'm going to introduce our speaker today. Our speaker is Dr. Sravanthi Nandavaram. She did residency at SUNY Upstate Medical University in Syracuse, New York, and she also did her fellowship in pulmonary critical care medicine there. This was later followed in an advanced fellowship in advanced lung disease, ECMO, and lung transplant. She's currently an assistant professor at the University of Kentucky in Lexington. And today she's going to be talking to us about VV ECMO and acute respiratory failure.
Good morning, everyone. Thank you so much for having me here today. Today I'm going to talk about veno-venous extracorporeal membrane oxygenation for respiratory failure in adults. I do not have any financial interest to disclose. In the next 40 minutes, I'm going to go over a little bit over the history of extracorporeal life support. I'm going to go over some current international registry data on ECMO use, especially the VV ECMO use. We'll talk a little bit about the physiology of VV ECMO and the evidence that we have so far for the use of VV ECMO. We'll go over some indications and contraindications, and then we'll see the effect of ECMO on other organ systems. And eventually, I'll end the talk by going over some current active studies in the field of ECMO. As we all know, respiratory failure is one of the most common diagnoses for patients to get hospitalized. About 2 million people get hospitalized with respiratory failure every year in the United States, and accounting for about $50 billion on healthcare cost. More than 140,000 of these cases are acute respiratory distress syndrome. And of all these patients, more than 50% of these patients end up requiring invasive mechanical ventilation, and the mortality in those patients is anywhere between 20 to 40%. So for such respiratory failure cases, the treatment can vary anywhere between a nasal cannula to invasive mechanical ventilation. However, sometimes in severe respiratory failure cases, despite being on high mechanical ventilator settings, some patients might need more measures to improve their oxygenation and to optimize their hemodynamic status. And in the last decade or so, we had so many studies looking at different strategies to improve the oxygenation. And of all these strategies, early neuromuscular blockade, proning, and titrating the mechanical ventilator settings to low tidal volume, high PEEP, and limiting the driving pressure have shown varied results, anywhere from improved oxygenation to improved survival, in addition to preventing the ventilator-induced lung injury. Extracorporeal membrane oxygenation is another mode of support which helps with the gas exchange in the extracorporeal circulation. It is not a treatment, it is not a definite treatment, it is basically just a gas exchange process. It is used only in situations where the disease process is reversible, and basically we are buying time until the organ recovers. And we can use this extracorporeal membrane oxygenation for respiratory failure or cardiac failure, or both. If we use it for respiratory failure, it's veno-venous extracorporeal membrane oxygenation. If it's for cardiac failure, it's VA ECMO. And if it's for combined, we can do hybrid VA and VV ECMO. Basically, we are ensuring patients' tissues are getting adequately oxygenated with the use of ECMO and gas exchange via extracorporeal circulation. And if you look at the history, the concept of extracorporeal gas exchange or oxygenating the blood outside the body was started in 1869. That was the first time Ludwig and Schmidt tried to shake the defibrinated blood with air in a balloon to see if we can oxygenate the blood outside a human body. And after that, there have been several attempts over many decades to oxygenate the blood outside a human body. And it was in 1971 that for the first time, the ECMO was used successfully in a patient. And this was a 24-year-old patient who was in a motor vehicle accident, had post-traumatic ARDS, and he was put on ECMO. He was on ECMO for 3 days, and eventually he was weaned off the ECMO and eventually got discharged. So this was the first successful ECMO use in 1971. You can look at the equipment over there. It almost took the entire room for that equipment. But right now, we can fit in like 4 or 5 ECMO machines in that room, and now the ECMO machines are small and they are portable. So after the first use of that ECMO in 1971, there were a couple of studies which were published in 1970s and 1990s, which basically dampened the use of ECMO. These studies basically did not show any survival advantage between ECMO versus non-ECMO groups. Rather, it showed significant complications in patients who were on ECMO. So that's how the ECMO use was dampened during that time. The inflection point occurred in 2009 with the publication of the CSER trial, wherein it showed mortality reduction in patients with ECMO group. And also at the same time, there have been an increase in the use of ECMO during the time of H1N1 related ARDS, and patients were surviving. With that, again, started the use of ECMO. And now, in current day and age, we use this ECMO, or the extracorporeal life support, for a variety of reasons. We can use it for respiratory failure, which is VV ECMO. We can use it for cardiac failure, which is VA ECMO. We can do hybrid ECMO for cardiorespiratory failure. We can use the ECMO for organ donation. It's extracorporeal donation after cardiac death. We can use it as a part of cardiopulmonary resuscitation, which is ECPR. And we can just use it for carbon dioxide retention states like asthma exacerbation or COPD exacerbation. It's just to remove the CO2. Extracorporeal Life Support Organization is basically an international organization which looks over the centers and the ECMO use. It's like an international registry. It maintains the international registry too. And if you look at the trend of the ECMO use, it's since 2009 that there have been an increase in the number of, since 2009, there have been an increase in the number of centers using ECMO and also in the number of ECMO runs in North America. And if we just look between 2014 and 2018, there have been about 8,200 VV ECMO runs for respiratory failure, and the survival is about 61%. And I'm sorry, I'm not sure if this is projecting well, if you can see, but basically I highlighted the survival trends over several decades here. So up here in 1980s, the survival was literally 0% for VV ECMO for respiratory failure. And between 1995 and 2006 here, the survival was like around 50%. And now the survival is about 64%. So there is definitely an improvement in the survival, at least based on the registry data so far. Let's take a peek on the physiology of the VV ECMO. So VV ECMO requires a central vascular access wherein there is a big cannula placed in a central vein and is connected to a pump. And the blood is withdrawn from the patient's body under negative pressure, and this blood is pumped into the oxygenator or the gas exchange device, and the gas exchange occurs in the oxygenator. This is where carbon dioxide is cleared and blood is oxygenated and is dumped back into the patient's body. And let's take a look at the oxygenator itself. Oxygenator is composed of hollow fibers filled with gas, which we call it as a sweep gas. And the blood flows around the hollow fibers. So again, the gas is in the hollow fibers and the blood is outside the hollow fibers. And just like our normal physiology that occurs across our pulmonary, alveolar, capillary membranes, the CO2 is cleared and blood is oxygenated by diffusion and because of the concentration gradient. So as the blood passes through the oxygenator, the blood gets oxygenated because of the oxygen that's moving from the fiber into the blood, and the carbon dioxide is moving from the blood into the oxygenator. And once the blood is oxygenated, once the gas exchange happens, as the blood comes out of the oxygenator, it's dumped back into the human body, and it's being dumped right across the tricuspid valve or in the right atrium on the venous side. So even though the blood is fully oxygenated here, which is exiting out of the oxygenator device, once it reaches the patient's body, it is a venous admixture. Because when we are drawing the blood out of the patient's body, it's only a part of the blood. The rest of the blood is still being oxygenated and is going through his native heart and lungs. And for cannulation, there are different ways we can cannulate the patients. One is single lumen double cannula, wherein this is the outlet cannula wherein the blood comes in, and this is the inlet cannula where the blood goes in. And this inlet cannula can be either in the IJ or in the subclavian vein. And the other is the dual lumen single cannula. It's also called the Avalon cannula, and it can be placed in the right IJ, internal jugular vein. And it needs to be positioned in a way that the blood that's coming out, which is the outlet part of the cannula, needs to be down almost into the inferior vena cava, while the inlet cannula should be facing across the tricuspid valve. And let's take a look at the oxygenator device. How does it work? The oxygenator device is also called as the membrane lung. What are the hollow fibers that I described? It's basically the membrane lung. That's where the gas transfer occurs. And the efficiency of this oxygenator depends on many factors. It depends on the membrane. It depends on the blood that's entering the oxygenator. It depends on the characteristic of the blood that's entering. In the sense, let's talk about the membrane. Membrane, it depends on the geometry of the membrane for the gas exchange to occur. It depends on the thickness of the membrane, and it depends on the membrane surface area. And let's talk about the blood that's entering into the oxygenator. How efficient the oxygenation happens depends on what's the saturation of the blood that's entering in, because as I just said, it also depends on the concentration gradient. So the saturation is important. The hemoglobin concentration, because oxygen binds to hemoglobin. And how fast or how slow the blood is going through that oxygenator. If it goes so fast that there is no time for oxygenation, it's not going to be efficient. If it goes so slow that the saturated blood is just sitting there, that's not efficient either. And obviously, it also depends on the FiO2 of the gas that we are supplying into those hollow fibers. And for at any given flow through the oxygenator, carbon dioxide clearance is more efficient than oxygenation. And the reason is carbon dioxide is a more soluble gas and is more diffusible than oxygen. So how does the oxygenation be affected? So DO2 is the delivery of the oxygen, CO2 is the arterial content, and CO is the cardiac output. So whatever the oxygen that we are delivering to the patient's body, or whatever oxygen is being delivered to each and every tissue in the patient's body, depends on the arterial oxygen content and the cardiac output. And in VV ECMO is the native cardiac output because it's not helping anything with the cardiac, with the hemodynamic support for us in the VV ECMO. It's a different story in the cardiac output. So just to recap, it's the arterial oxygen content. We all know this. It's hemoglobin times oxygen saturation times 1.34, which is basically the oxygen bound to hemoglobin, plus the oxygen dissolved in plasma, which is PO2 times 0.003. So in addition to ensuring there is adequate oxygen delivery at the tissue level, that helps us by reducing the need to depend on high mechanical ventilator settings in these respiratory failure patients. So that helps us in decreasing the pressure control or pressure support or PEEP, whatever that is, which in turn decreases the intrathoracic pressure. So that improves the venous return and improves the cardiac output and the hemodynamics in these patients. And also, it also minimizes the ventilator-induced lung injury with those high settings. Let that be volutrauma or barotrauma or atelectasis trauma. And also the myotrauma, it minimizes the diaphragm injury in these patients by reducing the ventilator settings. So as the native organ function improves, the need for extracorporeal support comes down, and eventually the patients can be weaned off the ECMO. As with any procedure, as with any other treatment, it has its own side effects and complications. And if we look at the complications, these complications can be related to the cannula, which can be a mechanical complication, or there might be some bleeding because these are like very big cannulas, 20 to 24 French cannulas. Or it can be related to the circuit as such. It's a machine, it's an object. So there is very good chance that it can be malfunctioned, and the blood is flowing through this, and through the object, there is always a risk for thrombosis. There's always a risk for pump failure. So in addition to cannula-related complications, in addition to pump-related complications, there can be medical complications too. And these medical complications can be either anticoagulation related, or can be infectious, or can be other organ complications with tissue injury, which I will go over in the next few slides. Of all the complications, kidney injury is the most common complication, accounting to about 20 to 25% of cases. And of these patients, about 3% of patients end up requiring renal replacement therapy. Now let's switch gears to the evidence that we have to support the ECMO use so far. This is one of the most recent studies that was published in JAMA about 2 months ago. This is actually a meta-analysis study which looked at different therapeutic strategies and compared different therapeutic strategies to improve the oxygenation and survival in patients with ARDS. As I said, it's a meta-analysis study. They looked about 25 randomized controlled trials, and they looked at 9 different therapeutic strategies. And they noted that compared to all the strategies or the therapeutic interventions that we have, comparing the low lung protective ventilation, proning and VV ECMO have shown to be associated with lower mortality, and this is the 28-day mortality. Saying that, if you look at the ECMO, there were only like 2 trials, and they're like combined, they had like 420 participants. And the overall mortality among all the studies that they looked at is about 35%. So basically, they concluded that in addition, or in comparing with the lung protective ventilation, the prone positioning and the VV ECMO use have shown to have a lower mortality. However, they couldn't come up with a guideline recommendation for ECMO as there were only 2 studies, and that's not sufficient data for someone to come up with a guideline recommendation. Next look at the EOLIA trial. This was published in NEJM in May of 2018. It's a study that looked at the mortality in patients with severe ARDS between ECMO versus protocolized ventilation management. And they had about 120 patients in each group. And they did not find any significant difference, like a significant p-value difference between both the groups in terms of mortality. However, what they noted is, if you look at the absolute numbers, the mortality reduction is much higher in the ECMO group compared to control group, even though they didn't see a significant p-value. So they concluded that this is a negative study. And the CESAR trial, the famous trial with which the major inflection occurred with the ECMO use, was published in 2009 in JAMA. This study was done at UK. We can debate about the study in many different ways, but this study was done at UK, and it's interesting that the way the study was done. They had 2 groups, and it's a randomized study. Each group had about 90 patients in each group. One group is ECMO, while the other group is conventional mechanical ventilation management. However, they didn't have a protocol. And this study was done at 69 centers. 68 centers were mechanical ventilation management group centers. 1 center was ECMO center. So the way the mechanical ventilation was managed in these patients was at discretion of the physicians at their respective centers. So there was no real protocol. Everyone did it differently. And only about 76% of those patients were on like low tidal volume ventilation. Versus there is only 1 ECMO center. Obviously, they had a protocol, they had very skilled people, and they took the patients on their discretion. So there are a lot of critics about the study, but despite all this, they have noted a better survival in the ECMO group compared to the conventional management group. So how to choose the right patient? Who will survive if I put them on ECMO? Who will not survive? How to say yes to a consult? How to send a patient for ECMO? So there are indications, though we do not have like clear-cut guidelines. Obviously, as I said before, the disease process should be reversible, and it is a temporary support. We are basically buying the time and let lungs recover and then get them off the ECMO. That's the whole goal. So any kind of respiratory failure, let that be infection, or if it's a primary lung disease, as long as it's not severe, and if you are confident that patient can go back to their previous baseline or at least can get off the ECMO, or any kind of post-traumatic ARDS or post-surgical ARDS or any other case of ARDS or pulmonary edema can go on VV ECMO. ECOR, or the extracorporeal CO2 removal, can be used for carbon dioxide retention states like asthma or COPD exacerbation. It can be used as a part of ECPR, and it can be used in any case of reversible rare pulmonary disease. And to assess how to choose patient, there are different scores which might help us at times to see if we can take these patients for ECMO. One is the Murray score. This is a score that was used in the CESAR trial to refer patients for ECMO. Murray score is based on 4 variables. One is the extent of consolidation on the X-ray. The other is the PF ratio, PEEP that the patient is requiring, and the compliance of the lung. And if the score turns out to be more than 2.5, they categorize these patients as severe respiratory failure, and such patients should be referred for ECMO. And the other score that we commonly use is the RESP score. It's the Respiratory ECMO Survival Prediction Score. This score is derived from the ELSO registry data. It is again a calculator based on different patient variables, which includes age, the status of their immune system, are they immunocompromised or not, the cause for their respiratory failure, the strategies that they are requiring to keep up their PO2 levels, are they on neuromuscular blockade, what's their CO2 level, are they on bicarb infusion, are they requiring to be proned. So once we plug in all the numbers, it gives us this graph basically which tells us their possibility, their prediction, their estimated survival if they go on ECMO. And if this turns out to be more than 80%, yes, that patient should go on ECMO. If it turns out to be more than 50%, at least ECMO should be considered. And in addition to the respiratory failure cases like this, ECMO can also be used as a bridge to lung transplant. And again, as I said, it can be used in chronic respiratory failure cases, but not in severe cases if the patient is not a lung transplant candidate. Let's look at the contraindications. I think as physicians, it's very tough for us to say no. Let that be a consult, let that be a treatment. I think it's kind of hard to say no when it comes to patient care. And it's very tough to say no to ECMO. However, we need to know our limits when we cannot do it. Age is not a real absolute contraindication. It's a relative contraindication as long as the patient before the disease process was in a good shape. However, any kind of non-recoverable morbidity that the patient has, that's an absolute contraindication. If someone has stage 4 cancer, terminal illness, those patients should not go on ECMO knowing that they will not get off the ECMO. And CNS hemorrhage is kind of controversial because nowadays we kind of do ECMO without anticoagulation. So it's not a real contraindication. However, if there is like such a bad bleed that the patient is herniating, of course, it's a no-brainer. They don't get ECMO. But small bleeds, which can be managed, or punctate hemorrhages, they can be considered for ECMO. And major pharmacologic immunosuppression is again a relative contraindication. And the reason I say that is studies have shown that the ECMO patients who were immunosuppressed, their mortality was higher compared to the patients who are not immunosuppressed. Saying that, again, as a lung transplant physician, we do ECMO after transplant if they have primary graft dysfunction and these patients are immunosuppressed. And they do well because we know that PGD, primary graft dysfunction, is a reversible process and eventually they recover. So knowing the patient well is the key factor in deciding who can get the ECMO and who cannot. So let's look at the medical management. So there is a lot of active research going on the cytokine interactions in these patients when they are on the ECMO. So when patients are on ECMO, the blood is going through the extracorporeal support, through the extracorporeal circuit, which results in cytokine release activation. It stimulates the coagulation cascade, which gets into a vicious cycle of cytokine activation, and this results in release of inflammatory mediators, and it affects at the end organ level and at the tissue level. And that's the most common reason for acute kidney injury in addition to the hemodynamic status of the patient. And it can affect any organ, the cytokine interactions. It can affect the hematological system, it can affect the renal system, it can cause liver dysfunction, it can basically affect any organs. And there is active research that's looking at something called heme adsorption devices. So basically the concept is to attach another part to the ECMO right after oxygenation before the blood goes into the patient body, which filters out all these inflammatory mediators, and whatever the blood is going back into the body, there are no inflammatory mediators, and we are good. However, it didn't make into routine clinical practice yet, because we are not sure this device, what is it doing to the drugs that we are giving to the patient? What's happening to the pharmacokinetics of the antibiotics, sedation, analgesics that we are giving to the patient? So hence it has not made into current clinical practice yet. So let's look what happens to other organ systems. So as I mentioned before, we can come down on the mechanical ventilator settings. We can let the lungs rest and recover. So that decreases the intrathoracic pressure, improves the venous return, and improves the cardiac output and hemodynamic status. And it improves the perfusion of the other organs. And if you look at the renal system, as I mentioned before, they are at risk for kidney injury, and sometimes they need the renal replacement therapy. Also saying that when patients are so critically ill, as we all know, they are going to end with positive fluid balance, and ECMO will help us with the negative fluid balance status. All we need to do is hook up the CRRT to the ECMO machine, and we can take care of the fluid balance too. And if you look at the neurological, obviously most of the times, by the time the patients end up on ECMO, usually they are either heavily sedated or paralyzed, so they are at risk for delirium. And in addition to that, as I mentioned before, if with the anticoagulation, there is always a risk for intracranial hemorrhage. And if you look at the hematological system, this is one thing that we deal with on daily basis. The blood is flowing through all these objects through the extracorporeal support circuit. So it's at risk for hemolysis and anemia. And with the activation of coagulation cascade, they can have hypofibrinogenemia, and they're at risk for bleeding. They can have acquired coagulopathy, and sometimes patients can have like a DIC picture depending on how dysregulated is their cytokine inflammatory response. And now let's take a look at what do we have right now, what active research is going on in the use of ECMO for these patients with respiratory failure. Actually, there are many studies going on, but I could put only like 2 studies up here. So one is the ASAP study, which is basically looking at the pharmacokinetics of the drugs that we give these patients, let that be analgesia, sedation, or the antibiotics. The other is the Lifeguard study, which is looking at the ventilation management for patients with ARDS. The other is the REST study, which is basically looking at protective ventilation in these patients. The other is prone ECMO. Can we prone these patients when they're on ECMO? It is not easy. It comes with a lot of risk and training the personnel who are taking care of these patients. But will that help us get these patients off the ECMO sooner? Solve ARDS, what's the right lung ventilation for these patients? Supernova, which is basically looking at ultra-protective lung ventilation in these patients. The other is the ProtectMO. When should we transfuse these patients? How long can I wait? How low can the hemoglobin go? How low the platelets can go before I need to transfuse? The other is the XXL, which is looking at the different therapeutic strategies being implemented in the ICU for gas exchange. And the other is the IDEA, what's happening to their immune system while they're on ECMO. So these are all the studies that are currently being undertaken, and I think it will take at least a couple of years before we will have any results from them. However, though we have some data, but still there are many more questions to be answered. Is it cost effective? How long is too long? How long I can keep a patient on ECMO? Is it weeks or months? And that's not going to be general. It's going to be patient specific, just like personalized medicine. And when can we have the definite guidelines to make our decisions easy? Even if a patient survives off the ECMO, what's their quality of life? What is their post-ICU syndrome situation like? Is it the same as any other medical ICU patient? Is it worse? How much can they do? These are all the questions to be answered. How many of patients will have kidney disease, and how long it's going to linger around? Are they going to end up on dialysis? How many of patients will have recovery of their kidney function? So these are all questions still need to be answered. With that, I'll end my talk, and I'll be happy to take any questions. Yes. No, we don't do that routinely. I have been at 3 centers and doing the ECMO, but we have not done that here. Do you do that here or at Jewish? Oh, okay. Mm-hmm. Yeah. Will that change your decision, like putting the ECMO or not? Mm-hmm. Mm-hmm. Patients. Got it. Yeah, yeah. I have not used yet, and I have not seen used so far, at least. Yeah, but that's good to know. We did one patient prone, and believe me, it wasn't easy. I mean, on ECMO, but before ECMO, yes, we try to do that. And usually, patients in medical ICU, they try to prone and they try to do. And the place where I'm right now, the University of Kentucky, we get patients from different fields, medical ICU, post-op cases. We get patients from other centers. So it's not in our protocol that we have to prone, but that's something that we are working on to see if we can do that. But so far, it's not a part of our protocol. But sometimes we do get patients from the medical ICU who are already proned, nothing has changed, and they end up on ECMO. But we did one patient, we proned and continued the ECMO. Any other questions? Great. Thank you.
So we wanted to present this as a token of appreciation for the Department of Medicine. This is, we give the slugger bat to all our guest speakers. So it says for Sravanthi Nandavaram, Medicine Grand Rounds, University of Louisville, November 7, 2019.
Great. Thank you. Thank you so much.